I want to thank Dr. Namrata and everyone else on the podium and also Ajanta Pharma for inviting me here. It's always good to be back home. Um, and I remember participating in this forum last year, but it was virtual, so it's nice to be with everybody else here. All right, we're gonna talk about collagen cross-linking a step before what Dr. Vanathi just presented. We don't want high drops to happen in the first place. I do not have any relevant financial disclosures. Just introductory slides about keratoconus. I'm going to stick to primary corneal ectasia, which is keratoconus, because I can only cover that much in a few minutes. I'm sure everybody in the room knows what keratoconus is. It's characterized by axial or paracentral stromal thinning. The only debatable number on this slide is the prevalence of keratoconus. If you look at the recent study, the RAIN study that was published earlier this year from data from Australia, the prevalence is actually up to 3%, which is way higher than what we were taught when we were residents 20 years ago, and that prevalence is less than 1%, or actually close to 0.1%. It usually presents in the second decade of life as diagnostics have become better. I'm sure whoever in this room looks after ectasia patients has realized that we see more younger patients now. What happens in keratoconus is the normal cornea, which is made up of um, cross-linked collagen. There's a reduction in number of these cross-links. There's degradation and displacement and rearrangement of these collagen fibers, and that's what leads to ectasia. What happens before the protrusion is actually a loss in biomechanical properties. We'll talk about that very briefly. Clinical presentation is progressive impairment of vision, myopic astigmatism, usually irregular. You can see a Fleischer ring on the base of the cone. Sometimes you see corneal scarring, which can be related to contact lens use. And also, as Dr. Vanathi presented, sometimes the initial presentation, especially in eye rubbers, is with acute corneal eye drops. Early signs can be both stria or Fleischer's ring, and late signs can be Munson's sign, Rizzuti sign, and a corneal scar. This slide just summarizes, I think this is from Praful Maharana's paper from AIMS RP Center, how variable the cone can look. The most common location is still inferiorly. You can see a central cone as well, which is always a good news if you're going to cross-link a patient. Central cones are easier to treat. We also use biomechanics, the Corvus ST device, which has been shown to pick up keratoconus before the tomographic signs actually are shown on pentacam or any such device. One of the indices that we use is TBI on Corvus, which is tomographical biomechanical index. It combines the D score from pentacam and the Corvus biomechanical index from the Corvus so that you can diagnose these patients a bit early. Towards the end of my second fellowship, I wrote a review in BJO about 12 years ago. Dr. Namrata was a part of that. And if you look at this slide, we don't do, or we don't want to do any of this as the first line of treatment nowadays. Every treatment modality in keratoconus 10 years ago led to a corneal transplantation. But it's important to realize that all these modalities, they improve the vision, but they do not alter the course of the disease. You can only change the central 8 millimeter of the cornea. So new goals of management are halting the progression of the disease and somehow visually rehabilitating these patients. We're just going to discuss the first part here. And the best way, since about 15 years now, if you look at the European timeline, is collagen cross-linking in order to stop the disease and try and reshape the cornea. We have enough evidence now that riboflavin-mediated cross-linking, it causes a frame shift in the amount of biomechanics, this biomechanical strength of the cornea. Very important, it is also a very cost-effective procedure. Of course, it depends on where you work, but in general, if you look at the graft registries, even the Australian corneal graft registry, you will realize the number of transplants that are being performed for keratoconus has gone down significantly just since the introduction of cross-linking, and that is very true for the United States eye bank registries as well, which are not very well kept. One of the first randomized controlled trials for cross-linking was performed at the University of Melbourne in Australia that showed that 3 years down the line there's a significant reduction in maximum keratometry and a significant improvement in uncorrected visual acuity. This trial was the patients were followed for 6 years actually, and that was published later on as well. Since then, multiple studies have been done and shown that although variable, but there's a reduction in the K values after cross-linking. About 80% of the corneas, they'll stabilize or even improve after cross-linking, and there is a modest improvement in uncorrected and best-corrected visual acuity after collagen cross-linking. Variations of cross-linking have been introduced. Cross-linking, the Dresden protocol cross-linking, it takes about an hour 10 minutes because you're soaking the cornea in riboflavin for 30 minutes, followed by irradiating that with UV light for another 30 minutes. So transepithelial cross-linking avoids removing the epithelium. You can also perform cross-linking in thin corneas by modifying the protocol. You can actually increase the energy that is delivered to the cornea, thereby using the term high fluence or accelerated cross-linking. And sometimes you can combine cross-linking with surface ablation such as PRK. The predictors of success, this data is from various studies, but overall, if you have K values which are more than 54, this is from the Melbourne study, patient is younger than 40 years and the cone is central, you can rest assured that your collagen cross-linking is going to be successful. There was a notion that collagen cross-linking in steep corneas does not work very well, but there was only one paper that was published saying so in 2009. Every single publication subsequent to that publication has shown that actually collagen cross-linking works very well if you have steep corneas, especially corneas that are more than 54 or even 58 diopters. We showed this back in 2015 that if you have a baseline Kmax value of more than 58 diopters, the cross-linking actually works very well. This is a patient, this is a subsorosity cassia showing the pre and post collagen cross-linking results. You can see the average K, it reduced from 55.4 diopters 1 year down the line to 52.1 diopters, about a 3 diopter change with an improvement in best corrected visual acuity. Another patient showing that 1 year down the line, the central K values improved from 70.7 to 64.8 diopters. So advanced keratoconus is definitely not a contraindication for collagen cross-linking. As I mentioned earlier, you can play around with the energy that is delivered to the cornea. You reduce the time and increase the energy. That really leads to better flow for the operating room and also comfort for the patient. However, at least 2 good studies, one published in IOVS, they have shown that if you increase the power beyond 9 milliwatt per centimeter square, the amount of energy that is released, that is not linear. So if you are planning high fluence cross-linking, the best is to try and stay below 10 milliwatt per centimeter square. We also performed a study some time ago where we actually compared conventional cross-linking with high fluence or accelerated cross-linking. The main limitation of the study was a small sample size, about 20 eyes in each group. As you can see, although there is no significant difference in terms of corneal flattening, but the amount of flattening after conventional cross-linking was 1.6 diopters compared to accelerated cross-linking, which was only 0.5 diopters. This is a study again telling us what I mentioned earlier a minute ago, that if you go beyond 9 milliwatt per centimeter square, the amount of effect that collagen cross-linking produces, if you just focus on this middle panel here, see how the cross-links, they become more regular up to 3 and 9 milliwatt per centimeter square, but not beyond that. This was done in rabbit eyes. So transepithelial cross-linking, as I mentioned, it's a procedure where we do not remove the corneal epithelium. Of course, it's going to be less painful. The visual recovery is quicker. It's preferred in pediatric age group. In some of the centers, theoretically, there's less risk of keratitis, but there are issues with penetration of riboflavin because of intact corneal epithelium. In various iterations have been described. People have used tetracaine, BAC, Prometamol and EDTA eye drops. You can also do a partial de-epithelialization of the cornea if you don't want to remove the whole epithelium. We did show in animal eyes that the amount of cross-linking effect that transepical cross-linking produces is actually less compared to epi-off cross-linking. So it is not true that transepical cross-linking works as well as conventional epi-off cross-linking. Some of the studies have shown that transepical cross-linking actually works, but the effect is very variable. We again performed a similar study showing that if the corneas are steep to begin with, typically more than 58 diopters, the Kmax can decrease up to 1.63 diopters even after transepical cross-linking. I'm going to skip this slide. Just a word about combination treatments. As I mentioned, some of the surgeons, they combine PRK and cross-linking and LASIK and cross-linking. There are studies out there showing that actually the amount of follow-up in terms of years is not enough to show the safety and efficacy of this procedure, and the protocols are not clearly well defined. So we try and stay away from these treatments. What is known, a light-emitting device described by Kaz Subota in Japan. Basically, patients wear the device, and you can actually do an epi-on riboflavin administration 3 hours daily for 6 months. There is a very small sample size clinical trial published in the BJO showing that this actually works very well in patients with keratoconus. Of course, this device is not available for clinical use elsewhere. Iontophoresis-assisted riboflavin delivery, it has been shown to be effective, not as effective as epi-off conventional cross-linking. A meta-analysis of more than 400 eyes have shown that there is a reduction in corneal curvature, which is comparable with standard epi-off protocols. Oral riboflavin has been recently shown to be effective, at least in animal eyes. There's a small case series that has shown corneal flattening with oral riboflavin. The major issue with oral riboflavin is the toxicity, the systemic toxicity of such high dose, especially on the hepatic tissue, liver, is unknown. We have been a part of pulsed UV light delivery. Elcon has a trial going on where you can actually pulse the UV light instead of sort of having a continuous wave light. The main advantage is that during UV light emittance, the oxygen, the free oxygen radicals are actually taken up very quickly. So if you pulse the delivery of UV light, you can actually increase the efficacy of cross-linking. In addition to pulsing the UV light, you can also create an environment of high oxygen saturation around the eye, and this has again been done by another trial from Avidro, which is now taken up by another company. One randomized controlled trial has definitely shown that periocular oxygen supplement with accelerated or high fluence epi-on protocol experienced a larger decrease in Kmax compared to the control group. We showed recently that you can use a modified ultrasound device to deliver the riboflavin on intact epithelium. The next step in this experiment is to actually mix oxygen at high pressure into riboflavin so that you do not need to provide oxygen from an external source. This is an ongoing work in animal eye. So to conclude, collagen cross-linking is recommended for progressive keratoconus. The corneal thickness has to be more than 400 microns as per the FDA requirements, and results show modest improvement in corneal topography and visual acuity, but there's no evidence to suggest that cross-linking is useful if your keratoconus patient is stable. I would like to thank and acknowledge my collaborators from other parts of the world without whom all these studies would not have been possible. Thank you very much for your attention.
Thank you. I think that was again all that was, and that is about the recent advances in collagen cross-linking. Is there any role of conventional cross-linking, or where would you want to do conventional and not accelerated collagen cross-linking? Since you showed that the results are quite comparable, except for the flattening effect, which is more with conventional than accelerated.
I'm sorry, I think you said, is there a role of conventional cross-linking?
Which cases you would want to do conventional and not accelerated collagen cross-linking?
So we still use conventional for two reasons. One is that's the only treatment available in the United States. Although I used to perform high fluence when I was working back in Hong Kong. And I think when I was in Melbourne, there was no high fluence at that time, so conventional was the way to go. But I have to tell you, the amount of flattening that you see with conventional is definitely higher than the amount of flattening that you see with any other modality of cross-linking. So it's still the way to go, especially if you are in a practice with younger patients. If you look at Farhad Faizi's data and other folks from Europe, you might have to repeat a cross-linking in a mean period of about 7 to 9 years. So let's say if you have a patient who's 22 years old, it is better to perform a conventional cross-linking in that patient so that you have the first major hit on that cone. You flatten it as much as possible and keep your fingers crossed. So I would still do conventional cross-linking in all my patients.
So Praveen, I think we've discussed this, and would you want to ask something? Nothing. Okay, what about, Vishal, what about, and I know what, I mean, I know Praveen knows what I'm talking about. What about in some of the cases we've had, like for instance, 7 of our cases where there is flattening years after you've cross-linked them, and so much so that they go into hyperopia. Have you come across this situation?
So no, we do not have such cases, and I know there are a few that have been published. We always think that whether it was primary ectasia in the first place or not is hard to tell. I do have certain other complex cases where we missed brittle cornea syndrome. We have 2 patients between me and Ken Nischel, who's the chief of pediatric ophthalmology. A young girl who had brittle cornea syndrome, and we made the mistake of performing conventional cross-linking or cross-linking at all. We should have avoided that. We have another patient who has arterial tortuosity syndrome, which can be associated with brittle cornea syndrome again. But I have not seen patients, at least in our practice, who have progressively flattened beyond 6 months or so. So if anyone has those cases, it'll be nice to follow them up and see what happens to their refraction and of course their corneal biomechanical properties over a long term.
So while conventional helps us have much more flattening, does it also cause more scarring or haze in the recovery period?
There are ways to reduce that intraoperatively as well. I'm sure everybody is sort of familiar with a simple task that is when you are soaking the cornea in riboflavin, you should remove the speculum. So the patient's eye is closed and there's no exposure to air and excessive thinning. That has significantly helped our patients in terms of reduction of haze. You can start a mild steroid like fluorometholone, not prednisolone, after the epithelium has closed. Most of the complications that we have encountered after cross-linking, especially infection, are because steroids are started very early post-operatively. I was taught in my fellowship that most patients will not need steroids, and that still stands true. My worst patients have been eye rubbers, patients with Down syndrome who have persistent haze that can last for up to 6 to 9 months. Surprisingly, this haze does not seem to be visually significant every single time. But I've not seen persistent haze. I know I did not discuss complication in the past 12 years or so since I've been performing cross-linking. I've seen one patient who had what we label as, endothelial shock, where we could see edema and polymegathism, but we just waited and it resolved. It took some time.